Hi, my name is Ashley Ward. I'm an oncologist, though I've been focused on developing new drugs for patients with cancer for over a decade now. I'm currently the head of clinical development at a biotechnology company called Macrogenics, and that means that I lead the team that designs, supervises, and interprets the data from our clinical trials. In the last couple of years, we've been specifically focused on developing new drugs for patients with prostate cancer, and I'd really like to thank the Prostate Conditions Education Council for giving me this opportunity to tell you about two of our ongoing clinical trials. They're both in patients with prostate cancer, and we're hoping that you or someone you love may be interested in them. First, I'd like to go over the current standard of care for prostate cancer treatment, which is, how are patients treated if they're not part of a clinical trial? When patients are first diagnosed with prostate cancer, they might get surgery, radiation, or even just watchful waiting. Sometimes they get ADT or androgen deprivation therapy, which is a treatment to get rid of the testosterone that may be helping the cancer to grow. If the cancer does start to grow or comes back, patients who weren't already on androgen deprivation therapy will start it. And many will also get another type of treatment called an androgen receptor inhibitor. Some of those include drugs named enzalutamide, apalutamide, abiraterone, or darolutamide. And all of those drugs block testosterone, but in a different way than the androgen deprivation therapy. If the cancer spreads or becomes metastatic, there are lots of treatment options, although most are still focused on blocking testosterone one way or another. For patients whose prostate cancer no longer responds to the androgen deprivation therapy, other options include an androgen receptor inhibitor, chemotherapy like docetaxel or cabazitaxel, a type of drug called a PARP inhibitor. Common ones include olaparib or rucaparib, and those are used just in patients whose cancer has certain genetic mutations. And then most recently, an interesting drug called Pluvicto that some of you may have heard of that delivers small amounts of radiation in a very targeted way to prostate cancer cells through an IV medication. So before I tell you about the work we're doing in prostate cancer, I do have a few disclaimers. So Macrogenics is a biopharmaceutical company evaluating investigational medicines for the treatment of metastatic castration-resistant prostate cancer. These investigational medicines have not been approved for use outside of clinical trials. Clinical trials are a really important step in the development of new medications, and we promote the participation in clinical trials by patients who are interested in helping advance the science. Volunteers in these clinical trials help us learn if the study medicines are effective and tolerable for the treatment of metastatic prostate cancer, and they might help other patients with prostate cancer in the future. All clinical trials and medical treatments come with some risks. And then if you're interested in participating in a clinical study, we always encourage you to talk to your healthcare team. So I mentioned a couple slides ago that I'm going to talk to you about two of our ongoing clinical trials that I'm really excited about. The first is called the Tamarack study. This study is testing two dose levels of a drug called vobramitamab duocarmazine in patients with prostate cancer. So vobramitamab duocarmazine, which I'm going to call Vobraduo for short, is a type of drug called an antibody-drug conjugate. So this type of drug has two parts. One part is an antibody, which is a really specially engineered version of a normal part of your immune system that is built to attach to a protein called B7H3. And that protein, B7H3, is found on the surface of prostate cancer cells. So it serves as a bit of an address of sorts. The other part of the drug is a tiny bit of a very powerful chemotherapy drug called duocarmycin. The antibody is attached to the chemotherapy with the intent of delivering it directly and specifically to cancer cells. That chemotherapy part that I mentioned, the duocarmycin, is really powerful. So if given by itself in doses high enough to treat the cancer, it would actually be deadly. But the beauty of this type of drug is that by attaching it to the antibody, we can just use very, very small amounts. Think of the antibody as like a mail carrier or a postal service worker who sends the chemotherapy just to a specific address so that all the other houses in the street, which are your healthy cells. We've already completed an initial study of Vobraduo in patients with a variety of different cancer types, including 40 patients with prostate cancer. 16 of those patients had cancer that had the potential of shrinking, meaning it was present in locations other than bones. So prostate cancer is often found in bones. And while we test our new drugs in those patients, we can't usually tell from CT scan or MRI of the cancer whether the cancer is shrinking in response to the drug, because part of the bone where the cancer is or was stays damaged for a long time until the bone can kind of heal or fill in over time. So we just don't see those changes very easily on CT scan or MRI. But for the 16 patients that I'm showing you on this slide, those patients had cancer in other parts of their body besides the bones, and we could follow those people with CT or MRI to see if their cancer shrunk when they got Vobra Duo. So each of these blue bars that you see represents one patient, and you can see that 4 out of 16 patients, or a quarter, the patients had their cancer shrink by at least 30%, and more than half had their cancer shrink by at least a little bit. So this study enrolled patients that had already tried all the other therapies that are out there, so we felt this was pretty promising. But then you might ask, what about those other patients, the ones that had cancer in their bones? So while we can't look for tumor shrinkage in every patient with prostate cancer, we can look at PSA levels on every patient with prostate cancer. So in this study, we had 39 of those 40 patients with prostate cancer that had their PSA levels checked before starting treatment and again while they were on treatment. Again, each of these blue bars represents one patient. So there were a few patients there on the left that didn't respond at all to Vobra Duo. Their PSA went up. So the line in the middle is 0, is whatever their PSA was at baseline. And if the bar goes up from the middle, then those patients actually had PSA increase while they were on study drugs. So they did not get any benefit at all. But all of the other patients, the ones whose bars go down from the baseline, they all had some PSA reduction on Vobra Duo. And in fact, 54% or more than half had their PSA level drop by at least 50% on the study, which is a commonly used indicator of an active drug in prostate cancer. When we test new drugs in patients, it's always important that we try to understand what side effects the drugs have in addition to any potential benefits. So I mentioned earlier that Vobra Duo is an antibody drug conjugate, and it has an antibody portion and a chemotherapy portion. Both of those components do come with some side effects. That postal delivery system that I mentioned earlier is not perfect. And so a small fraction of that chemotherapy component does fall off the truck, so to speak, en route, or gets sent to the wrong house and impacts the healthy cells in the body. So one side effect we saw on a little more than a third of people who got Vobra Duo on this first clinical trial is something called palmar plantar erythrodysesthesia. I find it much easier to call that hand-foot syndrome. So this is a condition that is seen with certain types of chemotherapy where the skin on the palms of the hands and the soles of the feet gets red, starts to peel, and can be very painful and itchy. About a quarter of people also develop some increased pigment or coloring in patches on their skin. Neither of those side effects is serious. They both go away when you take a break from the drug. They're not associated with major health consequences, but the hand-foot syndrome in particular can be very irritating to patients and can cause, problems with quality of life. About a quarter of patients develop a buildup of some fluid around their lungs, and about 11% develop a buildup of fluid around their heart. These are small buildups, very thin, and most of the time they can just be watched and they go away when you take a break from the drug, but sometimes they do require drainage with a needle or to be watched more closely over time. Some patients develop low blood counts while taking Vobra Duo. Specifically, they might have low numbers of the cells that help you fight off infection, low numbers of cells that carry oxygen through the blood, or cells that form a clot when you get cut. So patients with low blood counts might need transfusions or be at higher than usual risk of getting an infection or bleeding and need to take a break from Vobra Duo to recover. And then that antibody portion of Vobra Duo that I mentioned can also sometimes trigger an immune response called an infusion reaction. That happens in about 15% of patients and can cause symptoms like difficulty breathing, low blood pressure, fever, or racing heart. That all sounds pretty scary, but the treatment for these is really just stopping the infusion, giving some fluids and some anti-inflammatory drugs, sometimes a little bit of oxygen and some steroids, and it usually gets better within a few hours. So the side effect profile that I've just mentioned to you is actually pretty reasonable for a drug that's intended to be used in patients with prostate cancer that have exhausted their other therapies. But we think we can do better. And so one of our hypotheses or our questions is whether lowering the dose of Vobra Duo lower than what patients received on our first study could actually not only reduce the side effects that patients are seeing, but also actually paradoxically increase the efficacy by allowing patients to stay on study drug a little bit longer. That hand-foot syndrome that I mentioned caused some patients to discontinue study therapy because they didn't like the way that felt, which is completely understandable. And so if we can lower the dose and make that hand-foot syndrome a little bit more easy to live with, then maybe patients can stay on study drug longer and get more benefit. That's our hope. So the TAMARACK study is designed to help us answer that question. So patients with metastatic castration-resistant prostate cancer who have already received standard treatment for their disease, specifically, they've received a prior androgen receptor axis targeted therapy like abiraterone, enzalutamide, et cetera. And they may have also received chemotherapy, but they don't have to. Those patients will be offered the chance to enroll on the TAMARACK study, and they'll be randomized to one of two arms, but both arms provide Vobra Duo. So all patients who enroll in the study will receive Vobra Duo. There is no placebo. There's also no standard of care treatment arm. This is just a study looking at two different doses of Vobra Duo. So half the patients will get Vobra Duo at a dose of 2.0 mg per kg every 4 weeks, and the other half will get a dose of Vobra Duo at 2.7 mg per kg every 4 weeks. Mg per kg is milligrams per kilogram. It's just a way of dosing based on body size to make sure that everyone gets an equivalent dose regardless of their size. And the dose that we tested on the first study was 3.0 mg per kg every 3 weeks. So both of these doses are lower than that, and they're given less often, every 4 weeks instead of every 3 weeks. And then we'll be looking at how well the patients do on this study. We'll be looking at their PSA, whether it goes down. We'll be looking at their tumor size and whether it shrinks. We'll be looking at how long patients can stay on study before their tumor progresses, or their disease progresses. And we'll also, of course, be looking at safety and tolerability and trying to understand if lowering the dose really did help reduce the rate of those side effects I was talking about earlier. So we're really excited about this study. We opened it several months ago, and it is enrolling patients now in both the United States as well as other countries around the world. So if you are someone you know may be interested in participating, first discuss it with your healthcare provider. If you're interested in more information, you could visit our study website at www.tamarackstudy.com, or there's a QR code here that may be useful. This is investigating a completely different drug called lorigerlimab, but it's looking in the same patient population, men with metastatic castration-resistant prostate cancer. And this time, instead of looking at the study drug alone, we're looking at it in combination with a standard of care medicine called docetaxel, which is a type of chemotherapy. So lorigerlimab is a completely different type of drug than Vobra Duo that I was just describing before. Vobra Duo is an antibody drug conjugate. It's where you have an antibody linked to a little bit of chemotherapy. Lorigerlimab is a completely different type of drug that is intended to stimulate the immune system. It's one of a class of drugs called immunotherapy agents, or immune checkpoint inhibitors. So this drug is kind of an interesting design compared to other immune checkpoint inhibitors that are out on that have been approved for other types of cancer, in that it is a bispecific antibody. Bispecific means it has two specificities, so it's looking at two different checkpoint inhibitors with the same drug. So there are, in other cancer types, not prostate, there are quite a few PD-1 inhibitors that have been approved. That's the most common type of immune checkpoint inhibitor that is being used in cancer patients right now. So this drug targets PD-1, but it also targets CTLA-4, which is a different immune checkpoint. When I use the words immune checkpoint, our immune system has a lot of checks and balances that are designed so that our immune system can attack foreign invaders like bacteria and viruses and fungi, but will not attack our own healthy cells in our body. And so we have learned over the last decade or so that certain classes of drugs can remove the brakes on our immune system and remind our immune system that the cancer in our body is foreign and needs to go. And so the whole point of this class of medications is to stimulate the immune system, our own immune system, to fight off the cancer itself. And it's been very successful in other types of cancer, but so far not very successful in prostate cancer. And our hypothesis is that by adding the portion of this molecule that also, basically by targeting two of the brakes instead of just one of the brakes, that we can actually have some activity in prostate cancer. So that's the hypothesis that we're testing on this study. And this slide sort of describes in more detail kind of what I've just been talking about, that that PD-1, these two targets, PD-1 and CTLA-4, are both targets on our immune system that help our immune system learn to fight off invaders, including cancer. So we're hoping that by using one drug to block both proteins, we can actually help the drug be more specifically active against cancer cells than healthy cells, because healthy cells tend to not express both of those targets at the same time. We've also studied lorigerlimab in an earlier clinical trial that included patients with metastatic castration-resistant prostate cancer. And so these graphs that I'm going to show you are very similar in style to the ones that I showed you for Vobra Duo, in that each bar represents one patient. So this graph here is looking at the patients that had tumor outside of their bones that was potentially able to shrink in response to lorigerlimab. And if you think back to the slide I showed you before with Vobra Duo, you can see here that fewer patients overall had some tumor shrinkage, but the patients that do have tumor shrinkage have more deep tumor shrinkage than we saw with Vobra Duo. So that's really based on the mechanism of action, where we know that patients that therapies that target the immune system work really, really well in patients in which they work in, but they don't work for everybody. Whereas drugs like Vobra Duo that are more that include chemotherapy components tend to work in more patients, but maybe not for as long as the immune therapies do. So in this study of lorigerlimab, 26% of patients had their tumors shrink by at least 30%. So very similar response rate to what we saw with Vobra Duo. And here we're looking at PSA again. And again, think back to that Vobra Duo curve and what I just described. We're seeing a very similar picture here. So back in the Vobra Duo PSA curves, if you recall, most patients had some reduction in PSA. If you look at this curve, you can see that really only half of patients had a reduction in their PSA. So not as many people had benefit from lorigerlimab. However, those patients that did have benefit, those patients on the right side of this graph that had their PSA levels drop on lorigerlimab, had really profound drops in their PSA. They went to nothing. They went to zero. So we had I said 29% of patients had their PSA drop by at least 50%, but there were a substantial number that had their PSA levels drop by more than 90%, including all of those patients who had tumor shrinkage that was visible on CT or MRI scan. So there are some side effects that are associated with lorigerlimab, and these are very well known at this point, and very similar to the side effects that are seen with all of the other drugs in this class. So all immune checkpoint inhibitors like lorigerlimab have the same type of side effects, and all of those side effects are related to revving up the immune system. So remember, I said before that, we want our immune system to fight off bacteria, viruses. We want our immune system to fight off cancer. We don't want our immune system to fight off our own body, our own healthy cells. So when we remove the brakes of our immune system a little bit, like we do with lorigerlimab, we end up getting a little bit of risk of that our immune system is going to attack the healthy cells in our body. And the side effects that we see with lorigerlimab, we see rash. So if our immune system starts to attack our skin, patients can get a rash or itchy skin. We see symptoms from the immune system attacking our glands, like our thyroid gland or our pancreas, and that can cause hyper or hypothyroidism or diabetes. We can see the immune system attack the intestines, and that can cause diarrhea or inflammation of the intestines. And we can see our immune system start to attack our liver, and that can cause hepatitis. All of these are typically manageable. We've learned a lot over the last decade about how to manage this. Typically, it involves holding off on giving an additional study drug until our immune system calms down a little bit. Sometimes it involves giving patients steroids or other supportive care medicines. If their pancreas stops working, it involves giving, treatment for diabetes or treatment for hypothyroidism. There are, relatively small numbers of people that get each of these side effects. It's not like everyone gets all of them. Some people sail through immunotherapy with no side effects at all. Some people get, inflammation of their intestines. Some people get inflammation of their skin. Some people get inflammation of their liver. So it's usually sort of one organ that's the problem for any one individual person. And again, most of the time, these side effects are reversible and manageable with supportive care. And like I said, we've gotten pretty good at managing these over the last decade or so in patients with other types of cancer. And so that knowledge has really helped as we explore immunotherapies in patients with prostate cancer. So the LORIKEET study is investigating the combination of lorigerlimab with standard chemotherapy in the hopes of improving treatment outcomes in patients with metastatic castration-resistant prostate cancer. So this is a very similar patient population to the TAMARACK study that I just described, except that patients are not allowed to have had any prior chemotherapy. In this study, all patients get what we call standard of care. So patients who would normally be getting chemotherapy for their prostate cancer are eligible for this study, and they will all get chemotherapy for their prostate cancer. So there's nothing missing, okay? All patients will get what is standardly given for their tumor. Actually 2/3 of the patients will also get lorigerlimab in addition to the standard of care docetaxel. So this study is randomized, so you don't get to choose which treatment you get, but it's we're putting for every one patient that enrolls on the standard of care arm, the chemotherapy alone, 2 patients will enroll on the chemotherapy plus lorigerlimab arm. And our hope is that we will see that, that the addition of lorigerlimab helps improve outcomes for patients with prostate cancer. We know it will be a little bit more toxic than the chemotherapy alone. So, but we're hoping that it's not so much more toxic that it's not intolerable, and that the positive benefits outweigh the additional risks for patients on the arm. So this study just opened and is enrolling in the US, and will be enrolling ex-US very soon. So if you're interested, or one of your loved ones may be interested in this study, please talk to your doctor, and you can refer them to the description of the study on the website clinicaltrials.gov. That's all from me today. Thank you so much for your attention, and it was really a privilege to get a chance to tell you about our ongoing studies. We're very excited, and we're looking forward to continuing to make positive impact for patients with prostate cancer.
All right, Amy, thank you so much. We're going to go ahead and open the door here to some questions. Let's see here. So if you have any questions, you're more than welcome to type them into the window, the chat window there. We'd be happy to get those answered for you. We did have some questions come through online as well. So we'll go ahead and check to see if anyone has any questions here in the live session. Maybe while we're waiting for people to type stuff in, we can go ahead and ask a few of the online questions we got here. So one of them is there a cost to participate in the study, or is the study still actively enrolling?
So, great question. Both studies that I described in the video are still enrolling. There is no cost to patients for participating in the study. And I'll give a little bit more detail about that. So, when we as a clinical trial sponsor open up a study at a given trial center, which is usually a hospital or a clinic or some other oncology care center, we ensure that all of the procedures that are required for the study are paid for either by the patient's insurance or by our company.
Great. Another question we had, I think maybe it pertains to the blinding of the study or the randomization, but it says, does everyone get the medicine?
Yeah, that's a great question that a lot of patients are really concerned about when they're thinking about participating in a clinical trial. And it's important to ask those questions. I'll note that it can be different for every trial. So for whatever clinical trial you're thinking about participating in, you should ask a question about that trial. So I talked about two different clinical trials today, both for patients with prostate cancer. The first one for Vobra Duo, all patients will get the study drug and only the study drug. So they'll be randomized to receive one of two different doses, and they don't get to choose which dose they get assigned to, but they will all receive the medication Vobra, the investigational medication Vobra Duo. On the second study that I told you about, that's also randomized. Again, patients don't get to choose which study treatment they are assigned to, but 1/3 of the patients will be assigned to receive docetaxel, which is chemotherapy alone, and 2/3 of the patients will be assigned to receive the combination of docetaxel plus lorigerlimab.
Thank you so much. Another patient indicated, what if your doctor says he's not a study site?
Yeah, that's a good question. So all clinical trials that are conducted in the United States have to be listed on a website called clinicaltrials.gov that's maintained by our federal government. And it's a requirement that every single clinical trial is registered on that site. So you can actually, if there's a study that you're interested in, you can go to that website, clinicaltrials.gov, find your study, and there's a search engine that allows you to do this. Or in the video presentation for our two studies, I gave you the number of the studies, so you can quickly find it that way. But the one of the really nice things about that website is that it lists all of the active clinical trial sites for a study. And so you can go to that and see if there might be another study site near you, or your physician could go to that site and see if there's another study site near you. So if your doctor doesn't participate in the study, but it's something, and this applies to not just our studies, but any study that you might be interested in. If there's a study you're interested in that is not open at the place where you get your care, you may have the option of traveling to a place where that study is open. Sometimes there are lots of sites, and there might be one very close by. Other times there may be very few sites open for a clinical trial, so you might have to travel, and there may or may not be mechanisms to help pay for that travel if necessary. So that's something else that you can ask if you're interested in a particular clinical trial.
Okay. Another question we have: if we have to travel for the trial, do you have any compensation available?
Yeah, that's a great question also. So generally speaking, travel requirements for travel to sites would be paid for by the clinical trial sponsor, and that's kind of a sort of a general practice. It can be sometimes institution dependent, so there may be certain rules that the specific study site has regarding payment for travel. So it's something that you'd want to discuss with your doctor, because you'd want to understand whether that option is available for you at the clinical trial site you'd be going to. But generally speaking, if you're required to travel for the study, there are typically mechanisms to cover the costs of that travel. I do want to point out, though, that we don't pay patients to participate on studies. We never want, we don't want to create an incentive based on financial remuneration or financial payment to have patients make decisions that might not be in their best interest. So we do have a policy of not paying for patients to participate. We just cover their costs.
Another patient or another participant asked, essentially, can you stop participating, or what are like is there a criteria that a patient would have to fulfill to drop out of the study?
Nope, you are in charge. You can always quit at any time, no penalty. And that goes for pretty much all stages of participating in the clinical trial. You're in charge. You're the patient, or your family member is in charge, and we can't even like run any tests on you without getting your explicit permission. And then at any time, if you decide you don't want to participate, you've changed your mind for any reason, you don't even have to explain the reason. If you don't want to, you can withdraw consent. And that means that we discontinue study treatment, we stop collecting data on you, and we stop all the study procedures, and you and your doctor discuss what other type of treatment you'd like to go on to from there. So you're always, as the patient, you're always in control of your own participation, and you have the right to withdraw your consent at any time with no penalty.
Another patient online had a question asking, essentially, could these therapies open the door to future therapies for treatment of more localized prostate cancer instead of advanced stage disease?
Yeah, great question. I love that one. So that is always the hope. And I think I speak for all prostate cancer researchers when we say that it's very typical for new drugs for which we don't have a lot of information yet to be tested first in patients with very advanced disease who don't have a lot of other treatment options. And the reason for that is that we don't know what the risks or the benefits of these new untested drugs will be. And so we would not want to deny a patient an alternative effective therapy we know is effective for an untested drug. So we usually, most new drugs that are being tested for patients with cancer start in patients with very late stage disease who have tried other therapies and need to try something new. That said, if the early data show that there's some promise for new medications, then the hope is always that they can move into what we call earlier lines of therapy. So most typically they would be tested first in patients with sort of advanced or metastatic disease that have not received other therapies. But sometimes for promising therapies, we go straight to patients who have more limited disease. The reason why we have to be really careful about those patients is that patients with more, and we don't want to kind of rush to study new drugs in patients with limited disease, is that those patients frequently have a very good quality of life to begin with, and a long life expectancy. So often those patients don't necessarily need treatment at the moment, or if they got treatment, the goal would be to prevent them from having recurrence of their disease way in the future. And so we need to be very careful before we study drugs in those patients, because we don't want to do them harm, right? So we need to know a lot about a drug, and we need to know a lot about the side effects and the potential benefits before we want to risk testing it in a patient that already has a pretty long life expectancy and other good therapeutic options.
Very thorough, very well discussed answer, Ashley. That was nice. I appreciate that. And then looks like we have one more question. Do I need my doctor's referral or let them know I am going to be in a trial?
So if you're interested in a clinical trial, and this applies to our trials, but also pretty much any other trial, the first person to speak to is your own doctor, your own oncologist. And if you have a particular study that you're interested in, that's great. You can go and tell your doctor, hey, I heard about this study. It's called this. Here's the website. I'm really interested in it. Can you learn more about it? And let me know if you think this would be a good choice for me or if I might be eligible for this study. You're always free to do some research on your own, but your doctor may want to do some research on his or her own as well. And then, the decision about whether to participate in a study should be a joint decision between you and your physician, and, should not be influenced by the sponsor of the study. This is something that is really affects your health and is up to you and your physician to decide. So, I'm a huge advocate of participating in clinical trials. Whether they're ours or not is a lesser, I care a little, but I don't care that much. I mostly care about encouraging patients to be open to considering clinical trials, because that's how we learn how to make better treatments for patients with cancer. So every advance that we've made in terms of, getting new treatments out for patients with prostate cancer, for improving their life expectancy, for improving their quality of life, every advance we've made has been because patients like you or your loved ones participated on clinical trials that allowed us to ask questions and find answers and continue to refine our treatment methods. So I strongly encourage patients to look into clinical trials that they might be eligible for. Our studies might be one of those, but there are lots of other studies in prostate cancer. So, if you're interested in one of our studies in particular, you can take the name of the study or the name of the drug that you heard tonight, or you can even take the PCEC website and go to your doctor and say, hey, I heard about this study. Could we learn more about it?
That's great. And one more thing before we close, could you remind people how to find out about the study? You said you could just look up the drug name. Like, is there a website they can go to, or?
Yeah. So for the Tamarack study, we actually have our own website that we've built. That's called tamarackstudy.com. That's TAMARACKSTUDY.com. And there's a little bit of information about the study there, and some, that you can sort of it gives a way to find out more information. For the lorikeet study, we don't yet have a website up for that, but both studies can be found on the government website called clinicaltrials.gov. It's clinical, CLINICAL, trials, TRIALS.com. That can be a little bit tricky to find the study that you're looking for, but if you can look for the drug name, that's an easy way to find it. So that's probably the easiest way to find it. I've also, on the slide deck that you presented, put the direct link to the exact webpage on the exact portion of the clinicaltrials.gov that refers to each of those studies. But if you don't have access to that link, you can go to clinicaltrials.gov and type in either vobramitamab, if you're interested in the Tamarack study, or you can type in Tamarack. And if you're interested in the lorigerlimab study, you could type in lorigerlimab or lorikeet. And that's the search engine that's in the clinicaltrials.gov website should take you to the right page that will describe the study. And on that page is a huge amount of information that can be really helpful. It's probably most helpful for physicians, but it can be also helpful for patients. It has information about what the study treatments are. It has information about the purpose of the study and what we're trying to find out, like what questions we're asking as part of the study. It has information about eligibility. So it contains a list of the criteria that patients have to meet in order to participate on the study. And then it also has, like I mentioned before, a list of the clinical trial sites broken down by region, by state. So you can look and see if there's a site that's open near you. I will say that we are continually opening new clinical trial sites. So if you look at those clinicaltrials.gov pages and you don't see a clinical trial site near you, you may want to check back in a couple months, because we are continuing to add new sites, and we may be opening one up near you. It kind of depends on where you live. The other really neat thing about clinicaltrials.gov is that, and this is not helpful so much now, but for down the road, all of the clinical trials that are conducted in the United States eventually have to post their results on this same website. So if you go to the Tamarack clinicaltrials.gov description now, it'll have a description of the study. If you go and visit that same webpage in about, well, when we're done with the study, and we've collected and completed all the data, we actually will publish all of our data there. So you can go back and see, hey, what did they find out on this study? So it's a really great resource, this clinicaltrials.gov website. It can be a little bit technical, so you may want to print it out and bring it with you to your doctor's appointment and discuss it with your physician.
Well, I think that's the end of our questions here, Dr. Ward. On behalf of PCEC, I'd like to thank you for being here and for sharing this interesting studies and these interesting presentations with us. And we look forward to working with you again in the future.
Wonderful. Thank you all for your attention. I hope this was valuable, and really appreciate the chance to talk to you all.
Thank you so much. Take care.